Okay, so my name's Courtney. For all the attendees, I am the community coordinator here at Workit, and I'm joined by some of our great staff at Workit. They're going to go around and introduce themselves. So Tami, do you want to go ahead and start?
Sure. My name is Tami Wiggins. I'm the nurse practitioner. I work out of the Michigan and Ohio clinics.
Okay. Next, Paul,
next.
would you like to go? Okay, go ahead, Dana.
Sorry, I'm Dana Forman. I'm the VP of the clinical team at Workit Health. I'm based out of the Michigan office, and yeah, I'm currently seeing members there.
I guess I'll go next. I'm Kevin Armington. I'm the supervising MD for New Jersey and Ohio, primary care physician. I've done a lot of addiction medicine, and I've been with Workit for about a year now. And I'm really glad to have the opportunity to speak directly to patients tonight, more than one person at a time. So I'm looking forward to this forum.
And then I'm Paul Leonard. I'm the physician, emergency room trained, but also with experience in addiction care. And I'm the chief medical officer for Workit Health, and also really excited to be here today and get to chat with other great coworkers here and reach out to members and those interested to join.
Great, thank you. For all of you that have just joined, we're gonna go through and answer some questions that our intake team gets frequently, or that members of the Workit staff get frequently, so we can address some concerns you might have, or questions you might have as somebody looking to join or a member currently. And then the last 10 minutes or so, we'll open it up for a Q&A for anybody that has any further questions. All right, so the first question, can you give a brief explanation for people who don't know what Workit does, what we offer?
So I can start on this one. So Workit Health is a virtual addiction care platform where we offer not just addiction care specific to OUD or AUD, but we also now expand and take care of people might be suffering from anxiety or depression. And we do all this now completely 100% virtually, which is fantastic for those who might not be close to a center where they might be able to get care, and really helps us get to, our reach out to everyone. We are based now out of multiple states. We're based out of California, New Jersey, Ohio, Michigan, Washington, Alaska, and we are continuing to expand it to new states this year and next.
Great. Does anybody have anything they want to add?
I'll just jump in here. I've been doing addiction medicine for a long time, and when I started out doing it, it was clinic-based and office-based, and the obstacles to providing treatment to people were really considerable. And when I started doing offering treatment through Workit Health and actually able to reach people through telemedicine, the difference was incredible to me. You see changes in people really quickly. You're able to reach a lot more patients, and it's much easier for people. And as a clinician, to have such a much easier tool, kind of dropped in your lap all of a sudden, it just makes you feel so good to see the changes in people's lives so quickly.
I agree. I want to echo what both Kevin and Paul said, but specifically, the change that we see right away and the difference in the platform. Working in different office settings, I worked in a methadone clinic, and it was really, really difficult for people to be successful because they had to go to the clinic every single day. They had to pick up their medication. It was really, really difficult. Yeah. It's almost impossible to have a job or any other responsibilities if you have to be somewhere every single day and you have to go somewhere to do testing. So we are really putting everything that a member needs really in their phone or on their computer. And if they have a phone, they can literally do it from anywhere. So it's really incredible to see kind of the difference between an office-based setting and what we're offering here. And the retention and our success rates are just night and day. So it kind of just, like you both said, it's really great to be able to work with that and see so many changes quickly.
And then what made each of you interested in treating addiction specifically?
I can go first on this question. So I got interested in addiction because I came up through a household that surrounded by addiction. My parents were battling addiction, lots of family members, their friends. So I had a firsthand look at it, but I also got to see what happened when they had treatment and how they were different people, how they were able to turn their lives around and start to feel good about themselves. So being able to see the impact that can be made once people are able to get through treatment, that's exciting. And doing that every day right now, it literally gives me life when I'm seeing my patients and seeing the changes that happen in their lives, especially like Dr. Armington said, it happens quickly, you know, and to be able to see the successes and to celebrate with them, it's and you just can't get this in everyday medicine. You know, it's hard to see people with diabetes and hypertension and other illnesses, and you just don't see the turnaround as quickly. So it's awesome.
Yeah.
Yeah, I agree with you, Tami. I think we've talked about this before, maybe when you were first starting, and we were talking about the comparison to working in primary care before. And both of us mentioned, like you just said, you know, diabetes, you could be treating somebody for over a year before you see results. So with this, we're treating somebody, and even at the week mark, we're seeing great results. And in by month one, people are sometimes a completely different person in a good way, and they're back to their, you know, where they want to be. And so it's really cool to see that. But I also have a history within my family of addiction, friends, firsthand. So like Tami said as well, I've seen how important treatment is, and you know, if you don't get treatment, what can happen. So for me, it's really personal, and I just had a huge passion. There's such a lack of care and a lack of availability of providers, and that actually really drove me to go back to school completely and start completely over again, leave advertising and do this, you know, at like a little bit later than I probably would want to start a new career, but here I am. So
Yeah.
Super passionate about it.
Yeah,
Great.
I'd like to add on to that as well. For me personally, I'm still 100% working as a clinical ER doctor in the emergency room, and terribly difficult to see people coming into our departments across the country. But we work in multiple hospitals, and just seeing people coming in struggling and not having access to care. And we at Workit provide the gold standard of treatment, which is both medication as well as counseling, and we do it for people who, you know, basically have access to a phone, can get into our program. So that, seeing that opportunity was just, I had to help out somehow, and that's how I felt really, you know, I had to get on board with Workit and help expand our solution to this.
I'll also add to that personal experiences and family experiences made me really aware of addiction, although I didn't see so much of the treatment growing up, unfortunately. But I started out in medicine as a primary care physician, and mostly treating patients with HIV infection who had lots and lots and lots of challenges. And a lot of those patients had become HIV positive through sharing needles. And one of the things I realized pretty quickly was that we weren't going to get anywhere with treating the HIV infection if we didn't do something about the addiction. So I became very interested in treating addiction. And in those earlier days, there were very few tools available. And once I started really dedicating myself to this and seeing people's lives change because they addressed the alcoholism or they addressed the heroin addiction, they actually took their HIV medications. They became undetectable, and their diabetes got better. All of these things. So it was, I've come to addiction medicine through the back door, sort of primary care. And I'm glad I got here. You know, I still love primary care, but I'll tell you, there's nothing like seeing a patient on day one when you say to them, you know, we are going to treat you as an adult, as a human being, and we're going to help you through this. You don't have to feel any shame about where you're coming from, about what you've been doing. And, you know, we've got your back. We're in this with you. I had a patient last night who she had been with a the same doctor for 8 years, and she was ready to come off of Suboxone, and she really was legitimately ready to come off. Her doctor wouldn't take her off, and so she came to us, and because that's one of her goals is to come off of Suboxone, and for her to hear somebody say to her, "We respect your experience, and we're going to help you and help you achieve your goal, even if it may not be what we think is the right thing for you at the moment. If it's your goal, we're going to help you achieve it." And the gratification from that kind of an encounter, it just happens so frequently in addiction medicine that I'm really, really happy that my career path has brought me to this.
Great, thank you. So we talked about how telemedicine really makes it so that care is accessible to so many people. What's been something surprising that you've seen about offering care via telemedicine, and what's your favorite thing about it?
I can answer that. The thing that's been most surprising, I just really didn't expect to reach the faraway places like we have. It just, to hear people saying that they were making 3-hour drives, 2-hour drives, and now they can do this from home, it's mind blowing, so I'm sorry, they're cutting grass outside my home.
Okay.
But yeah, so that's been the most surprising thing, is that people are actually hearing from their friends and sharing, and it's growing so fast. And just to know that, people always say, and I've been telling people that I know about the program, and they'll say, "Oh, so-and-so's not ready." I hate when I hear that, because it's like, I just want you to share the information, because whenever they're ready, or if they just know about it, a lot of people think they have to do the traditional route. So that's why they're not ready, But if they know they can get help today, right in their home, by just downloading an app, they're calling, they're logging on, and it's just been so fast, it's just been growing so fast. So we can't even help quick enough, That's what's been really surprising for me.
I'll say for me, I was a little hesitant or worried about being able to build patient-provider relationships without seeing somebody like face-to-face first. But it was really surprising to me. We used to, laws required a patient to come to the office for their first visit, and now that's gone. So at first when that happened, I thought, how's this going to go? Are we going to be able to build this strong relationship? But it's been wonderful. I think people are, and I saw it before the first appointment was required in person, but even without that, people I think are more comfortable. They're in their home, they're in their own environment. They feel, they're not in an office where it's kind of like a stark setting and have like a white coat syndrome and get really nervous. They're in their own environment. We're in our own environment. So I think it makes it a lot easier for people to just be open and honest and feel more at ease and not so nervous and afraid to share. It's not easy to come in and meet somebody and spill all of these things. It's a hard thing to do anyway, but to be able to do that from the comfort of your own home, I think really makes it a lot easier, and it helps us build better relationships. I think I've really seen that.
I also think the really amazing thing about telemedicine is that it's accessibility. I mean, people can go on their lunch break, have a meeting, talk with their counselor, their provider, and get back. I mean, as opposed to, I have a 15-minute drive, how am I going to get there? How am I going to get back? I can't make this work. That's out of the equation. So now people can really build this into their house, or into their lives, if they're from home, for example, and that allows them to stay part of the program, work around the other things they're doing within their lives. And that really is a game changer for us.
I think the most surprising thing is I was concerned, like Dana, about, when you take away the formality of the clinic setting or the office setting, that people won't take their medical care or their interaction as seriously. And what I've really seen over the last year is that it's really good to take that formality away. And people are much more relaxed. they're at ease much faster, so they're able to really tell you in a really forthcoming way much faster what's going on with them. I also really love having the spouses in the background, because you don't always know that you have an audience, but sometimes you do have an audience, and then you'll hear somebody from off screen say, "That's not really the way it is. Let me tell you what's really happening." so I mean, sometimes you get a lot more information because the patient is in their setting, their support system is there. You learn about their lives. You know, for young mothers, you see just how much time they have to spend taking care of their child. And, you know, you begin to realize their challenges in terms of taking care of their medical care and you know, all of their other responsibilities. So one of the big surprises for me has been being given this window into people's lives and their homes. And I think that's made me a better doctor, and it's made us develop relationships, I think, faster and in a more meaningful way.
Great. So when people are interested in the Suboxone program, a lot of times they're really interested about the transition process. They're not sure how it's going to go, what's going to happen. Will they need to stop taking opiates entirely before their first visit? Who wants to answer that? Dana, do you want to answer?
No one wants to take that one first.
Whoever.
Well, no, you know, before they take their first dose of Suboxone or buprenorphine, you know, they'll have to be in withdrawal before they take the medication. Otherwise, they'll get really sick from taking it. So if they've been taking Medicaid or opiates up until, you know, even the minute before their appointment, as long as, you know, we can have a conversation with them and explain the steps, and we feel comfortable that they are understanding how to do their score and how to take the medication appropriately, when to contact us if needed. You know, they can start it when they're ready. We give them all tools that they need to be able to do that, but they don't have to be, you know, off of opiates the day of their appointment or prior to coming. They don't need to be in withdrawal. We can, you know, walk them through that and how to do the induction process at home. Also, with that being said, you know, we also know that some members do struggle to and still use opiates, you know, for a period of time when they're joining our program. So I think we're going to talk a little bit more about this later, but harm reduction is a really big part of what we do here. And it's our kind of our main focus, so to speak, and really what we stand behind. So we understand that, you know, there may be times when people are still using when we've, you know, started them on medication, and we want people to be able to come to us and let us know, you know, I used opiates this week. I, you know, was having a lot of cravings. I don't think my dose was where it needs to be. You know, I was thinking about it a week and I ended up using. Whatever it may be, you know, we can work with people when they're honest about their use. So, no, they don't have to be off of opiates when they come for their first appointment.
Okay, thank you. So as you said, Workit is a harm reduction based program. Can you explain what that means?
Yeah, I don't know if somebody else wants to go or I can talk again, but I can give just a short overview of my perspective. It's meeting people where they're at, and when they're ready to quit what they want to quit, we'll help them quit that. So for instance, if we have somebody that comes to us and they are, you know, using cannabis, they're using opiates, they are ready to stop using opiates, they want to continue, you know, using cannabis, we will talk with them about certain, you know, dangers with smoking, for instance, or maybe recommend edibles, things like that. Talk to them about the guidelines within the state for using the substance. But ultimately, you know, we want to meet them where they are. So if they don't feel like they want to quit, you know, cannabis, they don't have to. We'll educate them, provide them with the materials that they need. And, you know, our real focus is you know, meeting people where they're at and what they want to do in their recovery.
I'll add on to that. You know, as the chief medical officer for Workit and working along with Dana, you know, we spend a lot of time making policies and programs that are always, the goal is to keep people involved in part of our program. We are trying to stay away from kind of that traditional punitive approach, which is, one strike, you're out. I always say the analogy is similar to working out. If you said, all right, tomorrow you have to eat perfectly and work out every day and you can't have any mess ups, no one would ever do it. It's impossible. So why would we change the approach here? It's about working with our patients and our members about how to keep them, getting through the journey. And the data is clear that, harm reduction keeps people involved longer. It leads to longer success for people staying in the program, and fewer opportunities where patients might have problems where they feel like they want to leave the program. So the harm reduction model really is actually, I would argue, in the best in the best interest of the patient, of the member. And so we are always trying to do that. And I know a lot of members come from programs that don't necessarily share that mindset. And I think there's a reason why people stay with us so long. And I think that's a big part of it. But that's kind of really the general concept, is keeping people in the program as long as possible. Like Dana said, our members, we have great data show they're very open about their obstacles and difficulties. And when we aren't trying to catch them, so to speak, we have a better success. They might say, this week I had I might have used something, and I want to talk to you about what might have been some of the triggers, why that happened, how can I prevent that going forward. And ultimately, it's just a better relationship between the provider and the member.
Right. And real quick, I want to add, and with that, then we can do interventions, right? So if people are honest about what's going on, instead of, trying to hide things, then we can help them with those things. So if they use cocaine, we can reach out to their coach and say, hey, can you reach out and do a one-on-one? This person's struggling a little bit with this, and let's send them a course that is related to cocaine use. So, with honesty, we also can perform some interventions that also I think are really beneficial for the members.
Just to piggyback off of that, I always tell my new patients that we use the drug screen as a tool, more so as a self-check for them. We're not trying to play gotcha at all. And that we use it to tweak the treatment plan, just to be able to figure out what's going on. We want them to be completely honest and open so that we can help and figure out what little thing might be holding them back from having long-term sobriety. In the beginning, you have the physical issues that you're dealing with, but then there's going to be environmental issues, there's going to be social issues, and we want you guys to feel comfortable sharing that with us so that we can, if we need to have your coach involved or refer you to other resources and things like that, that can, and then also preparing with other tools so that you can deal with maybe things like anxiety that may have been a trigger to using and things like that. Those are the things we want you to be comfortable with sharing with us so that you can achieve long-term sobriety. A lot of people have been through treatments and they weren't successful just because they weren't comfortable enough to be able to share those little things. And so they weren't able to get the support they needed. So we're all about providing you the support. We're like your biggest cheerleaders. The thing about Workit is that it's been a good job in terms of getting people who are on board with harm reduction, on board with the idea of making sure we reach people so that they can get treatment and things like that. So everyone here is really, really on board with being cheerleaders for everyone. So that being said, I tell patients, that you're, if you've ever heard you're not your credit score, I tell them you're not your drug screen. We use an overall approach and we look at the whole picture. Have you been doing your courses? Have you been engaging? Overall, what have you been doing? Have you been having personal successes? You know what I mean? Yeah. So we don't just look at a drug screen that may not be what we want to see and sum it up and say, okay, that's it, you're done. We're here for the long haul.
I love what Tami just said about, you're not your drug screen. It reminded me of how we used to say in the early days of HIV treatment, you're not your T-cell count. You are so much more than that. And that's just such a great way to put it in perspective. The thing, harm reduction to me means that the relationship is a collaboration. Is that, we are working with you. Traditionally, the doctor, the provider patient relationship has been a real power differential. And with harm reduction and the approach that we take, the emphasis is on talking together about what are the options and making a decision together. And as a medical provider, I need to tell you what your options are. I don't need to tell you exactly what to do, but I need to tell you what are the possibilities and what are the potential outcomes for these. And whatever you choose, I'm going to help you with that. And this is a collaboration. It's not a one-way relationship.
So many people wonder about Workit's take on marijuana. Can Workit members use marijuana recreationally or medically? And if someone is using other substances, how can they start a conversation with their provider about this? Does anybody want to go
jump
first?
in here quickly? It's a really tricky question, because obviously the status of marijuana is changing so fast in our country that I would say that we're trying to change with the times. Can people use marijuana and be treated with Workit Health? Absolutely. We would never ever deny treatment to somebody because they were using marijuana. A lot of people actually have a medical indication for it and have a medical card to be able to buy marijuana legally. And so for those patients, it's much simpler, that this is part of their medical treatment. For others who are taking it for reasons that are unclear or really struggle with it and is part of their addiction, then we need to help them with that. And if their goal is to stop using marijuana, then that's part of their treatment plan. It's a harder thing to treat than opioid addiction because we don't have a very good medication for it. But I think that the best thing to come out of the really open discussion about marijuana of the last few years is alluding to what Tami was saying, which is that people are being really honest with us about what they're doing. And that helps us to treat you better, is to know exactly what it is you're doing. I just want to reiterate, nobody would ever be asked to leave treatment because they're using marijuana. That's part of the life, is that a lot of people are using it today. And sometimes it's a good thing for them and sometimes it's not. When it's not a good thing for them, we try to help them to stop using.
I agree with everything Kevin just said. You said it perfectly. In Michigan, where it's, per our state law, even though it's legal in the state of Michigan, it does impact, drug testing frequency and things like that. So along with what Kevin just said, I also talked to my members about that, and if they're eligible for a medical card, to try to obtain that, just for their own, ease of testing. But I agree, if it's something they don't want to quit or it's not creating part of their addiction, then, we just I like to educate on, the harms of smoke and things like that. And like I said earlier, maybe trying edibles, but it's never something that we're going to say, nope, you can't have treatment here because you're using marijuana, so we want to provide the resources if needed, but, we kind of leave it at that from my perspective.
Yeah, I think Kevin and both Anna, they really nailed it on the head there. I think the other part to Courtney's question about other substances people might be dealing with, we also help there as well. And we continue to expand our policies and our programs, every month to offer more services. So if someone might be having some issues with cocaine, methamphetamine, alcohol, nicotine, all these things, are also have addictive portions to them, we can help. And while everything isn't necessarily as clean, so to speak, as treating opioid use with having medicines available, we have courses, we have counselors who have experience to treat you for those things as well. And like Kevin mentioned, it's all about that comfort. So if you can tell us what you're dealing with and working, up against, we can help. So we are all about wanting to know what it is that you're really struggling with, so that we can kind of meet you there. But we have programs in place for all those other things that people out there are dealing with.
Okay, and how does drug testing work virtually? And what is Workit looking for when they do drug testing for members?
That
Anybody?
one, I don't need the information since I don't do them. I can talk about the frequency maybe a little bit. So in the beginning, frequency is going to be weekly, well, in Michigan. And I guess, is it different in different states?
Yes.
Okay.
It is.
Okay.
Yep.
So yeah, so it just depends on the state that you live in, but you definitely want to have drug screens completed before your first appointment, and also between your other appointments. If you're due, the app is going to send you a notification. You're going to have 48 hours to complete it. If you don't, you would have to go to confirmation testing in your local community. But for the most part, though, you just want to make sure it's up to date, because the providers cannot refill your script if the drug screen is not up to date. But it's all done through the app, though, and you don't have to leave your home to do it, though. That's the biggest thing.
Yeah. Oh, go ahead, Paul.
Dana. Well, I'll let Dana talk about the specifics, but basically it's kind of, we work with each state. Each state has different rules about this, but for the most part, generally speaking, it's about a once a month process to be done. It can be done at home through our app. We have the ability to literally to walk you through the process, and you can dip the urine drug screen and show it to your counselor, who can kind of confirm, and she can talk. Dana can mention exactly what we're looking for in there. It's a 10 substances. However, the ability that you can do it from home once a month and work with our counselors in the sense that we have drug testing hours every day, that you can go do this. It makes it really easy essentially for people to do this process. We do have confirmatory testing as needed, but that is not our first line way we test our members.
Yeah, agree. So piggybacking on what you just said, so the long and short is people can do their tests from anywhere, really, if they're in a private place. So if somebody's at work and they are on break and it's, they need to do a test, they can go into the restroom and do a test there. If they're, at a friend's house or at a family member's house and have a private area, bathroom where they can do their test, they can do it there. So it makes it really convenient for people, instead of going to an office or going to a lab every single week, month, whatever the state regulations require. So I think that's the big thing with our program, is that we offer that ability, which makes life easier. Like Paul said, we do ask people to go for testing if needed at the lab. And what we're really looking for in the test, the main thing is we want to make sure that our members are taking the medication that we're prescribing them. And we also want to make sure that they're telling us about their drug use. So if it's positive for cocaine, for instance, and I meet with this patient and they say, yes, on Tuesday I used cocaine, that way we can have a conversation about it. So we're really looking to see what their use is, talk to them about that use, and also make sure that, they're taking the medication that we're giving them. It's not for like a punitive measure. We use these as talking points to see what's going on with them, what's going on in their life, what struggles are they having, like Tami was talking about a bit ago. What areas do we need to work on? Are you having cravings and you're needing to use opiates? Talking about dose increases if necessary. So we really use it as a tool to see how they're doing and if we need to make changes to their treatment plan, while making it really easy for them to do the test at the same time.
Probably will want to add that they're mailed out to them, so they don't have to worry about running out or getting them or anything like that. They're mailed out.
Mm-hmm. Yep, so they can order them right on the app, and if they have like 1 or 2 tests left, then they just hop on, place the order, and then it's shipped right to their house. So very convenient.
I think that there's a stigma attached to doing urine testing, and I think it's really unfortunate because you can look at it as the way we test in other illnesses. What we're looking for is we want to see, is the medication working for you? And if we're seeing other opiates in your urine, medication isn't either it's not working or the dose is wrong. And that's exactly what we do with somebody with diabetes. We check their blood sugars, their long-term blood sugars every 3 months, their hemoglobin A1C. We want to see, is the medication working? And if it's not working, we need to make some adjustments. So I would really like to see this recast as, what we would do for any disease, which is we look for some objective way to monitor how someone's progressing with their illness. It's not at all about gotcha. And I know a lot of people come from it with that idea because they've been in programs where it has been used very punitively, or they feel some stigma, which I think there's so much stigma around treatment for drug addiction in general that it kind of spills over into how we monitor for it. It does need to be done. It gives us important information, but it's really about patient safety. It's about nothing else but patient safety.
What happens if a member relapses, and what steps should they take if they do relapse?
I'll go with this one. The best thing to do is, if you relapse, is to definitely show up for your next appointment. I have so many patients who have had an issue with relapse, and usually the issue is shame, but I always encourage them and let them know that they showed up. That's the biggest thing they can do, is to show up, not run away, not hold your head down. And I tell them, hold your head up. You showed up, you're still fighting. So that's what you want to do, because what we're going to do now is, like Dana said, have the conversation about what was going on, what were the circumstances, that led up to this. Most of the time I'm going to hear something like the environment. I found something around the house, a friend called. So we get to be able to put those things in place to help support you, maybe your dose was too low. Your medication may need to be increased. So we figure out what's going on that way, but we can't help you if you don't show up. So that's the biggest thing. Don't run away. Don't say, forget it, I fell off, and just, decide you're just going to start using again. Come back. That's the biggest thing you can do.
100% what Tami just said. I always tell my patients, if you show up, I show up. So no matter what's happened between, then the last time I saw you, I'm going to be there. So as long as you're there and we can talk about what happened, we're good. But if you don't show up and I don't know what's going on, probably, then who knows what's going to happen. So just show up, be honest. And that's the best thing you can do. And like we were just talking about, let us know what's going on so we can kind of get to the bottom of things, whether it's a med issue, triggers, things like that, and really address those. Do courses, do one-on-ones, increase the dose if needed. But you got to show up and be honest. And reach out right away. If you don't have an appointment for 3 weeks and you had a relapse, reach out on the chat. Let us know, hey, I need to be seen sooner, and we can get you in, no matter how busy we are, we'll squeeze you in there. So
I just like any other relationship. Oh, sorry, Courtney, just very quickly, relationship, it's like any other relationship, you need to show up. If we're, we want to see you, we want to see what's going on. We want to see what happened since the last time, even if it's bad news. And, when you don't show up, it's a real disappointment for us. Not only are we not helping you, but we're left wondering, and we want to know. We're curious people. We want to know what's been going on and how things have been, even if it's negative, you take a step backwards. There's no single disease that anybody could treat where somebody is 100% successful every time. And that's just ridiculous. And addiction is the same way.
I want to add, I tell my patients that, I'm personally invested, in your success. This is not just a job for me. I really get excited with the successes. And I'm here to support. So definitely don't think that, we don't care when you don't show up. That, like Dr. Armington said, we are wondering, it's like, we really become attached and personally invested in how you guys are doing,
I know this is kind of a hard question to answer because it's different for everybody, but about on average, how long will a member be in the program for? And what happens when they're ready to get off the Suboxone?
I can start with this one, at least kick it off. So this process is not a quick process. And it's something that we, on average, have most of our members at least 1 to 2 years involved with our program. And that's something that is both physical in the sense that when you're going through the process of getting off, something that your body has become physically addicted to, it takes some time for your body, your brain to kind of restructure itself so that it cannot necessarily have those triggers. I say it's almost the same thing as your phone. You look at your phone all the time. It takes time when you don't look at your phone and go, okay, where's my phone? That's something we don't control. So that process to kind of change that thinking and it just takes time. So we don't expect anyone to be out of our program, I would say no sooner than 12 to 18 months to really see long-term success. I mean, like everyone has said over and over, we are in a long-term journey with you and we want to see you successful. And, it would be unfair to tell our members that this is going to happen quickly because it would just kind of set them up for some false promises. That being said, what is the long-term goal? It kind of is what is your goal? I mean, everyone is different. And that could be, the way I think about it is if you take blood pressure medicine, you take blood pressure medicine maybe for the rest of your life, but so be it. I mean, no one ever says that's a bad thing. It's just, maybe you don't need it one day, but if you need it, you need it. And if that's something that our members need, a low dose of Suboxone or a steady maintenance dose, and they can participate in their lives and have meaningful relationships, that's a win. I mean, what more do you need? However, like Kevin kind of alluded to one member, if someone is trying to get off of Suboxone, we can do that too. So it's not necessarily like Courtney said, it's one answer for everyone, but I would say those are kind of the general timelines. Those are kind of the general, I would say, thought process of where for our members, where, what is your endpoint? What are you looking for? Because I think we can meet you there.
I would add to that, you want to make sure that everything else in your life is stable. The last thing you want to do is say, I want to get off Suboxone and chaos is happening in your personal life. So you want to have stable relationships, you want to have stable financial backing, and whether you're working, whether you have an income coming in monthly, you just don't want to say, okay, I'm ready to get off, but all of the stress is coming at you, because if you're going to set yourself up for maybe starting to use something else again, if that's, if stress or anxiety was a trigger. But that'll be a good way to figure out. I also tell my patients, if you're starting to notice that you forgot to take medicine, you know what I mean, and this is happening more frequently, then we can discuss tapering, as a goal, if that's what you're noticing.
Agree with both of you. I don't know if I have anything else to add, but I really want to say that it's really patient-led. So, if somebody has to get off for maybe financial reasons, or if they're going to jail, for instance, and they can't take medication in with them, and they know they have to go in 2 months. And so, we can work with people if they have to get off of it within a timeline. But ideally, 1 to 2 years is what we've seen works best in our practice and research as well. But with that being said, we of course will work with our members to help them if they need to wean down earlier. And we also have a variety of medications that we can use at the end of the taper to help with those symptoms that they might experience as their dose gets, from like 2 milligrams to a 0, to be able to help with those things.
Great. This is the last question before we open it up to the Q&A. A lot of people during the intake process ask if you guys can prescribe their other medications for them as well. If they're on like anxiety medication, do they still need to see their primary doctor? Can you guys take over prescribing that medication for them?
Shall
I guess you want to go? Go for it. You want me to? Okay. So this is, literally, it's funny. This is a great leading question because we are in the process of adding new programs to Workit Health. So, you know, from where we were 2 years ago to where we are today, we are able to do more for our members. And that includes now treating with medications for anxiety, depression. We now are expanding into other kind of, I guess, smaller things like insomnia and nausea, other things like that. We also, you know, and this is kind of one of those tricky things, because when you start to get so involved with members and, you know, they say, hey, I trust you. I think we have a great relationship here. They might want to say, can you help me with my other medical problems? And while we might not technically be PCPs, we do have the ability to kind of continue on medicines that are fairly stable and not changing. You know, that being said, we do, if our providers feel that something will be better managed by a specialist, or a PCP should be really the one driving that, then we will defer accordingly. But now, you know, our latest new initiatives, we will be able to start you on and prescribe and maintain medicines that would be related to those other diseases we just discussed. So that's really exciting. It's new. I think it's something that we are literally the last 3 to 4 months have offered. But like I said, it's kind of comes down to, you just ask your provider, say, hey, I've been on this medicine for a while. I can't see my PCP. And, you know, like I said, I think at the end of the day, we'll work with you. I mean, most of these things are very low risk. So if you need a refill for something for 30 days until you see someone, I don't think that's a big deal. That being said, if it's something that, you know, is concern, or it's say, hey, you know, you're having nausea, maybe we should see someone and make sure we're not missing something else, I think we will do that, because at the end, we have to make sure that we are treating you, you know, correctly. And like I said, some other things we also do is now Hep C, and we're also offering PrEP, which is basically prophylaxis exposure for potential patients who might have concern that they might be exposed to HIV, for example. So we offer medicines for that. Hepatitis C, which is incredible now, is literally either a pill a day or 3 pills a day for literally 8 to 12 weeks and is curative. We can do that as well. So those are some things we offer in addition to kind of what we're, I'd say, best known for. We can do those things.
I think that was really, really well said, Paul. And the only other thing that I might add is that, you know, if people come to us and they want us to continue a medication, they should expect that we're going to do an evaluation, you know, because prescribing a medication is a serious responsibility. And so if it's something that seems very appropriate and has been working for you and is within the realm of the things that we're treating, I don't think it's going to be an issue for most Workit Health providers. But I think that also patients need to realize that we're going to think about what it is and whether, you know, what our experience is with these medications. We may have a different recommendation, but it's not an automatic thing. I think that, you know, for many things, it will be pretty easy to do that. But there will be some discussion and some evaluation as well.
Agree. I think you both summed it up well.
Great, thank you all. We have a few questions in the Q&A, so I'll go through these. For an addiction medicine trainee, what are some of the tools and skills you think are important to integrate when thinking about entering into the field of addiction medicine?
I can start. I would say, obviously, you know, doing waiver training is really important. Can't do it without it. And also, I think shadowing somebody is really helpful. You know, when we had the clinic open before COVID, that was part of what we did for our interview process. And I think it's just really helpful in general for any job, really, to really get like a hands-on experience with what you are going to invest your time and commitment to doing. So, you know, having if you're kind of on the fence about what you want to do you want to do addiction medicine, really finding somebody that would be willing to let you come in and kind of shadow and watch how the ins and the outs work is really important. Because things are different than they may seem on paper, obviously. So
right.
Always recommend that.
Yes, I would say you definitely want to understand the population. So whether it's, I believe there's some books, I would have to look up the list. I don't have it off the top of my head, but whether it's books, whether it's some related reading and some literature that you would want to do, but you want to understand the population because it's a little bit different. You got to have patience. It's not for everyone, and so you want to be able to. If you're just doing it because you heard this might be the next big thing to do, you're going to burn out, and you're not going to be in it long. And the patients really deserve to have someone who really has a heart for this type of specialty, because it takes patience. No one is able to say, okay, I've decided I want to be sober today, and tomorrow they're completely sober. You know what I mean? It just doesn't work like that. So you have to understand that people may a little bit, they may, take a while to get there. And you have to be able to not have any that judgment or stigma. Just you have to check yourself for all of that.
Agree. You have to have a true compassion if you want to be, happy in this role and successful, and have happy patient population, really. So really agree with that, Tami.
I would recommend going to some 12-step meetings. You'll learn a lot about addiction and about what patients struggle with, and things that you'll never learn in medical school or NP school. So great background for working in addiction is 12-step meeting attendance.
Thank you all. See, does your practice integrate microdosing for patients with OUD? And how does Workit Health balance treatment options when someone has more than one substance use disorder?
We have some cutting edge questions out there. As far as I know, we're not formally doing microdosing, although we do certainly, and Paul and Dana may be able to speak to this better than I or Tami, but as far as I know, when people have been using fentanyl, for instance, inducing or starting buprenorphine can be a little tricky. And so we may have them start on much lower doses within the confines of the medications that are currently available. So cutting the strips into smaller and smaller pieces. But actual microdosing, as far as I know, I'm not aware of us doing that. But I think it's certainly a discussion that we need to have.
Yeah, I think Kevin says it great. I think microdosing is something that's, I guess, we don't formally do it yet. I don't think there's necessarily a need for us to be doing that. If our members really come to us and we feel as a community that's something that people can really benefit from, then I think we could always consider things. I mean, I think that's what we're always doing.
Right. I
mean, at Workit, we're always kind of changing things, open to suggestions, adding things. But formally, no, we don't do microdosing. That being said, we have a great range. I mean, we as a range from what we can offer for buprenorphine. I mean, we can do very low dosing, high dosing. So I think that covers the gamut for the vast majority of our patients. As for the other options, I think, like we've said and kind of discussed earlier, we offer treatment for more than just one substance, and our counselors have ability to help patients who might be dealing with more than just one issue at a time. So we are more than capable to do that. We're building a platform that already does that, and we'll do more. So I think that's kind of where we want to get, which is I don't just, have an issue with one, but any substance use, whether it's even medicine related. I mean, like I said, we have a large amount of members that only need counseling help. They don't necessarily need medications. And we do that because it's more about what does the member need, not so much, hey, just because we have something, you gotta take it. It's kind of, what are you dealing with? How can we help you best? And so I think that's really the key question there. But we do more than one substance, and we kind of check in with you and see where things are and what you might need help with, at the time, if it's more one thing than the other.
Agree. We've really been trying to position ourselves as a wraparound, care company. So we want to be able to be, a member's one go-to for as much of their medical needs as possible. So, we continue to expand and add new things and new treatments and new programs as we grow. We're really, right now focusing on the things that we're most commonly seeing. But as Paul mentioned earlier, within the discretion of the provider, there's a variety of other things that we can also treat. So we're really trying to be kind of the go-to, and people don't have to go to 5 different providers to get all of their medications. Ideally, we would like them to be able to come to us and get as many of those as we can prescribe.
All right, and last question. How do you know if Workit is the right option for a patient?
Jump in, give it a try.
Yeah, I would say that really the only, the only time that it's probably not a good option is if people don't have access to internet, which is pretty obvious. But, if people don't have reliable phone or internet connection, it can obviously make it pretty difficult to have our appointments. So really that's the only barrier that I would say. And even that can be overcome. A lot of libraries have like private rooms that you could rent out that, you would be in your own room without anybody else in there. So it would be a private area. There's a lot of options that we can suggest for those members. But to me, I think that would really only be the biggest barrier to care. Anybody else?
Yeah, I'm thinking like it's pretty darn hard to come with a reason why Workit might not work for you. I mean, we have really taken all the barriers and either remove them or have solutions for them. And I would argue, show me a program that has better accessibility than we do for our patients. I mean, you don't need a car. You don't need, you need a phone, which I'd say pretty much like Dana said, almost everyone has a phone at this point in time in our world. And we can meet you there. We can work with you. We can do more than one, issue at a time. We have providers that, can work pretty much most of the hours of the day. You have a chat, you can talk and get a response back within 24 hours. I mean, these are the barriers of why addiction care up till I'd say the last 5 years has been a struggle, is that it's not necessarily the process, it's that people can't get there, they can't make the call, they can't get connection. We've taken that out of the equation. So I think that's why our success, speaks for itself. But I would say it's really hard to have a reason for why Workit might not work for them. So I'd say, like Kevin said, you got to give it a try and try it out.
Yeah, I've had patients who are at work. I've had patients who literally are wiping the sleep out of their eyes. So there is literally no reason that this is the easiest way to be able to get treatment. You don't even have to brush your teeth before you see me. So just as long as you show up, we can help you.
Right. And even with like the tech issues, like I said, we have a whole slew of people that can help with those things. So, even if that seems like it might be a barrier, we can probably work it out. And we have a lot of different ways that we can help work through those things. So, like Kevin said, give it a try. Usually it works out pretty good, I think.
Great. Thank you all. We got through all our questions. I appreciate you guys for joining.
Thank
you. If anybody would like more information about Workit, you can check us out online at workithealth.com, and you can look us up on social media. We are Workit Health everywhere.